afternoon, everyone. It's a great pleasure to be here with you this afternoon. I'm going to present two important questions. One is, have the recovery rates for common mental health disorders such as anxiety and depression, have they stagnated? Are we not able to push above 50 or 60%? And the second question is, has CBT lost its effectiveness? As some of you may have seen in The Guardian fairly recently an article that argued that CBT had lost its effectiveness. They argued that when CBT first became popular here in the UK, that it was shiny and glittering and it was the gold standard, and therefore the effect that therapists had with CBT was due to the placebo effect. Now, I'm going to argue that that's not the case. I'm going to argue that CBT is an effective intervention and it can be even more effective so that we can increase the recovery rates and ultimately make more people better. Now, I'm very privileged to have a very exciting data set at my fingertips. So as Chief Clinical Officer at Ieso Digital Health, I can do something that I've never been able to do in my career as a CBT therapist, a manager, a lecturer, a supervisor. I'm actually able for the first time to really understand what therapists are doing in the therapy room. So we have a vast data set. Not only do we have the clinical outcomes in terms of recovery and reliable improvement, the patient experience questionnaires, engagement data. This is common data that many services now have, particularly, of course, within IAPT. But we have something that's far more exciting than that. We have the therapy transcripts of over 14,000 completed cases of people that present with an Axis 1 disorder. This is a game changer because we're able to drill down into the therapy transcripts and understand what is it that the therapists who are delivering this intervention, we've got 500 BABCP accredited therapists, what are they doing that makes a difference? So here on this slide you can see an example of how we deliver CBT online using written communication. So our therapists and our patients don't see each other and they don't speak to each other. They communicate by writing. So we're using typed synchronous communication. So patients and therapists are reading and writing. To all intents and purposes, what's going on in that session is absolutely identical to face-to-face CBT. We're not using modular materials, we're not using web-based disorder-specific materials. We are delivering CBT per protocol in an idiosyncratic way. It's just that the medium is a bit different. And I can tell you with pride that the clinical outcomes for delivering CBT using this method are absolutely identical to face-to-face CBT, so this works. So we did an efficacy study in 2009 which demonstrated that this method has efficacy. But I think what's more important than that is now in 2017, with over 14,000 patients, we have effectiveness data. And that, I think, is something that's far more important. We know, because we have to publish our data in the public domain, that this method is equally as effective as face-to-face. And I'm here saying that actually, rather than being a panacea, that this isn't something that I think that should replace face-to-face. What I want is that every patient in England has a choice whether they have CBT face-to-face or CBT online. So something really important happens when you put a computer between a patient and a therapist. What actually happens is that we have a standing research platform. So we're able to actually ask some very important questions like, how do you increase the recovery rate for patients with anxiety and depression so more people can benefit and more people can get better? We have very interesting data sets. So the slide that you see before you is an example of our dashboard. So of the 500 therapists that are working with us, each one of those has a data dashboard. And that tells us, what is that therapist really good at doing? Are they more effective at treating one disorder rather than another? And one of the things I care passionately about is that I want the therapists that work with our service to be the very best therapists they can be. Because that's the only way I foresee that we're actually going to make a difference in this important work that we do. So we're using this data in a very supportive and enabling way by asking our therapists and using our data to say, what are you really good at and what can we help you do better? Now, over the last 3 or 4 years, I've been doing quite a lot of research. So with that many therapists treating that many patients, I asked myself, what is it that the therapists who get consistently good outcomes, 60%, 70% above in terms of recovery rate, what are these therapists doing that's making a difference? And conversely, the therapists who are in the bottom 10%, and I'm sorry about the pejorative language, but the therapists who aren't doing so well, what are they doing that means that they're consistently not getting very good recovery rates? And we've got some very interesting data. There's a very, very strong theme of the therapists who are at the top and getting really great recovery rates. They're doing 3 things. Does anybody have any idea what those 3 things are? So I'll tell you. One is that these therapists have fidelity to the CBT model. They are delivering CBT and not something else. And we can measure that using a tool called the CTSR, the Cognitive Therapy Scale Revised. And this is a validated tool that assesses fidelity to the CBT model. So they score very highly on that consistently. They also adhere to the evidence base. They are using disorder-specific treatment protocols to treat patients, and they stick to those protocols. The third thing is slightly more subjective. They are scientist practitioners. That means they are reflective, they're generally quite critical and humble, they are hungry to learn, and they learn from every single patient they treat by reflecting on that, seeking guidance, going to CPD events, seeking supervision. So they want to get better and better at what they do. Now, the people who were unfortunately not getting such good results, they were doing none of the above. And the interesting thing here is, with 500 therapists, about 90% of the therapists that are working with us to deliver treatment within the NHS, within IAPT, about 90% of these therapists are working within IAPT as well. So it's a very representative group. So it's large numbers and quite representative of the therapists who are out there treating patients within the NHS. So this is really interesting stuff. The second thing that we're doing is that we are now looking at 100 therapists who have the highest caseload, and we are trying to quantify their effectiveness. And we're doing this with something that I've called the Ieso equation. So this is a way of quantifying clinical effectiveness within an IAP setting. So we're looking at doing several CTSRs, looking at adherence to evidence-based protocols and stepping back and asking ourselves, do these people display the qualities of a scientist practitioner? And one of the things that we're beginning to notice as we look at not the top and the bottom end, a real spread, is something very, very interesting. So what we're beginning to see is probably about 80% of these therapists are displaying significant drift away from the CBT model and significant drift away from the evidence-based. And that's problematic. And I think, and it's a Sarah Bateup hypothesis, I think that's why people like The Guardian are saying that CBT has lost its effectiveness. It's a bit like, when we learn to drive, we learn how to pass the test. We know how to pass the steering wheel between our hands and when we should be looking at mirrors. But when we've passed our test and no one's staring over our shoulders and assessing and examining us, we start to do all sorts of stuff. And therapists are exactly the same. And those of you that know the literature will know that lots and lots of people are suggesting and hypothesizing that the reason why we're not being able to replicate the RCT data in CBT is because therapists drift away from the model. And if you're doing an RCT, you make damn sure that your therapists are delivering whatever it is that you want to deliver. But managers of services aren't able to actually understand what therapists are doing in the therapy room. Going back to this idea of being a scientist practitioner, some of you may not be familiar with the term scientist practitioner. And one of the things that I've observed, both amongst our 500 therapists, but also in my time of teaching and supervising clinicians in a number of universities, is that being a scientist practitioner, I think, is crucial. So a scientist practitioner displays these qualities. They're curious, hungry for information. They're very reflective, both in action and on action, so after they've completed treatment. And they tend to be very humble people who tend to think that they're not very good. And one of the things that I've noticed is that if a clinician displays these qualities, that what happens is that they've got very firm foundations on which they're able to learn, so that the building blocks of learning get taller and taller and taller because they're built on firm foundations. And conversely, if a person is not a scientist practitioner, that actually those firm foundations are not solid, and therefore what you're building doesn't get as tall, so they don't get better and better and better. And I think that this has implications for universities in how we select the clinicians of the future, because I think that if we can get better at assessing, is this person a scientist practitioner, in which case we can build and get them better and better. They will learn and they will really make a difference out there. This is another way of increasing the quality of the treatments that we provide. So you might have seen in a couple of slides ago that I talked about the 8-stage model. This is another invention, for want of a better word, based on our observations. So as we looked at a number, I think probably about over 4,000 completed cases, and we began to look at when the outcome of therapy is not very good, what's happening, what's going wrong? So I've already mentioned therapist drift is one issue. But there are 8 stages where therapy can go wrong. And the first stage is the assessment stage. It's kind of not surprising, it's not rocket science. So if the clinician is assessing a patient and they come up with the wrong primary presenting problem, they're going to be treating the wrong thing. It's a bit like treating somebody for a cold when actually they've got meningitis. The outcome is not going to be very good. So actually helping clinicians to come up with the right primary presenting problem, to consider a differential diagnosis, could it be something else, to use the right measurement tools is absolutely essential. The next stage is actually thinking about, well, what disorder-specific treatment protocol do I use for that disorder? Because remember, adherence to the evidence base is absolutely essential if we're to get good outcomes. So picking the right protocol, and then more importantly, is sticking to it. So time and time again, particularly in patients who have depression, what we see therapists doing is something that I call the scattergun approach. So rather than sticking to a protocol to the bitter end and working through that with somebody, they're actually trying a bit of this and a bit of that and a bit of the other. And when patients do that, the outcome is always poor. This next stage, so the 6th stage, is a collaborative review with a patient. So actually round about session 4, working with the patient and asking the question, are you finding this helpful? Is this moving you towards your goals? Are you starting to see some benefits? Or actually, is this not really for you? It's not the right time to have therapy. It's a chance to really reflect and think about, am I doing a really useful piece of work here? Or do I need to seek help to make it a more effective piece of work? Or actually, is this not really working, and why? And then as we move towards the end of therapy, it's really helping a person prepare to end therapy and to take the learning that has been derived from the therapy session and use that to maintain the gains. And lastly, the 8th stage is back to the scientist practitioner principle. So it's getting the therapist to reflect on every single patient that they have worked with and to use that experience to learn and to become a better therapist. So we're taking all of this information that we have, all of this learning, and in order to enable therapists to be the very best they can be on our site, by creating a therapist assistant. So we're using AI and our AI scientists not to be patient-facing, but to be therapist-facing, to enable therapists directly in action to gain from our insight and learning, so that we can help therapists when they drift away from the model, so we can help therapists when they're not recognizing that their patient isn't engaging, and we can help therapists recognize risk. So this is really exciting, and this is where it becomes a game changer, not for Ieso, but for all patients, for all CBT therapists, because we are able to actually ask some really important questions. So our research going forward in 2018 is looking at how do we push up the recovery rates for patients with depression, and what are the most effective change mechanisms that we should be using in order to help more people get better. And this is what I mean when I say this is a game changer. Having such a huge data set, such a large cohort of therapists, we're actually able to use the platform because we have the transcripts, we can see and test what's working and what's not working to really derive that learning and really focus on doing something that's really important. So my argument therefore is CBT is just as effective as it has ever been. It's just that we need to help therapists avoid therapist drift, and we need to get them to adhere to the evidence base. And then the world is our oyster, and we are not going to rest on our laurels. We want to push the recovery rates up time and time again so that more and more people get better. Thank you.